Thanks, Joshua, for the introductions. And yes, Esther, we can move to the next slide. We're on right before for the learning objectives. So thanks everyone for being here today. We're so excited to be able to share with you and also hear from you. So I'll just give a brief overview of the session by going over some of the learning objectives. So we'll start by describing some of the struggles experienced by long-term care village when it comes to grief. And then we'll go into some of the strategies that we've observed and seen from research that may be promising for honoring grief. And then throughout the presentation, we'll also be pulling in some BC-based grief and bereavement resources to help increase some awareness of what's available to support individuals and care teams. Next. So to begin, it's important to understand why grief is a significant experience to pay attention to in long-term care. So what do we know about grief in care homes? First, it's often the last place where residents die. So death is expected for many here, and each year, about 1 in 4 residents living in Canadian long-term care homes will die in the home. Death is often considered the final outcome for many of the residents admitted. And so admission kind of will mark the beginning of a lot of residents' gradual decline, bringing a lot of loss related to health, independence, identity, and relationships. Second, we also know that residents in these homes can live here for sometimes months or years, which is a little bit different than other care settings. In Canada, the median survival after admission to long-term care is about 18 months. And so there's a lot of opportunity for residents, families, and staff, and the entire village making up long-term care to develop ongoing relationships with one another, which can make grief and loss feel even more personal and challenging to manage at times. And thirdly, long-term care homes tend to be a little more resource constrained compared to some settings, often without adequate formal or informal grief and bereavement support compared to maybe like hospice, for instance. And in BC, we don't have a standardized mandated process for grief and bereavement. And although our provincial guidelines do recognize grief is a core component of a palliative approach, there is no technical or licensing expectations for long-term care homes to support residents, families, and staff. And so some of you may be working in healthcare, might be familiar. We have the Long-Term Care Quality Framework Policy Directive, which is a document that sort of provides quality indicators to help care homes monitor the quality in these care homes. But it currently doesn't include anything related to grief and bereavement. And so just wanting to note that that's a key limiting factor because often the barrier in care homes is not just education or a lack of leadership prioritization in the home. It may be beyond the care home. And so as a result, grief support practices may vary widely across different homes. And unfortunately, more often than not, grief tends to remain more hidden or not very acknowledged in long-term care. So taken together, the lack of adequate support in a unique setting that does foster close bonds and experiences repeated cycles of loss means that grief is very significant, yet it's under-recognized in long-term care. And this should be a huge concern because grief affects everyone in the care home. It shapes residents' quality of life. It influences the well-being and the engagement of families and care partners, and it can also contribute to much moral distress and burnout among staff. So it's a significant issue and something we believe deserves more attention. And next slide. So here I have a few quotes that speak to the significance of grief and end of life that come from a focus group that the BC Centre for Palliative Care did with families who are currently supporting loved ones in long-term care. So the family member here expressed that they noticed death is often the final outcome for most residents, but they also observe there's limited conversations about end of life, and it's just not very visible. Next. And a quote from another family member here captures kind of the specific questions around grief that they find sometimes go unanswered or are not clearly defined. Like, for instance, how much time do families have before a resident's room is cleared? And so these conversations, they matter to families, but there may need to be more done to support conversations and resources that honor these grief experiences. And these sharings tell us that talking about grief matters to people in long term care. But before we go further into the presentation, it may help to pause and consider what grief actually is and how it may appear in everyday life. So, Lisa will provide some background on what grief means and how it may show up in our lives. So, next slide.
All right. The range of feelings we experience when we lose someone or something we cherish in our lives is known as grief. Grief isn't good or bad or right or wrong. Grief just is. Bereavement is the overall period of experiencing this loss of a significant person, while mourning is the active outward expression and public display of that grief. The external manifestation of our inner emotions is mourning. People tend to believe that grief shrinks over time, but what really happens is that we grow around our grief, and mourning is crucial to how well or good we will perform following a loss. Next slide.
Yeah, thanks, Lisa. And just now that we've kind of reflected on what grief is, we also wondered if you feel comfortable sharing. We have a few questions that Esther will pull up for everyone to respond to, and it's just asking about your own experience with grief. So the first question is, have you experienced grief or supported someone experiencing grief? And if so, what did you do to support your own or someone else's grief? So I can see some answers coming in, and there's quite a large amount of people who have experienced grief themselves or supported someone experiencing grief. About 98% of respondents. So it is a very shared experience. And then for the second question, what did you do to support your own or someone else's grief? 86 people responded, and 99% shared that they did have experiences of grief. So as I continue, we'll just try to keep in mind kind of how we've defined grief here and then move towards talking about the types of grief. So as Lisa mentioned, grief is an expected and it's a normal reaction to loss that changes over time. But when it's not acknowledged or validated, it can become difficult to live with. And so, one of the key messages we wanted to communicate through this presentation is that grief is not tied only to death. There's invisible grief and there's visible grief. For visible grief, that's usually death related loss, such as when a spouse or a friend dies, because you can see it and there's more recognition or social support for it sometimes. Whereas for invisible grief, it can often be non death related, not often described or visible to the outside world, and that can limit the opportunities that we have to acknowledge or support it. An example could be loss of privacy, lifestyle, independence. And next slide. And so, as we describe some of the types of grief we've observed in our experiences in long term care, I will start with disenfranchised grief, which is defined as grief that's not openly acknowledged, publicly mourned, or socially supported. It's when society or people around you don't validate your loss. And from long term care, it seems many of them risk becoming disenfranchised because they are not easily seen or acknowledged. And one example I have to share is when I've been volunteering, sometimes I see residents move to a different floor or a different area of the care home because their needs are changing. Or I knew of one woman who moved into a larger room with her spouse when she arrived, but she later moved to a smaller room after her spouse had died. And there was this sense of loss around losing the home that they had set up in the previous room, the familiarity around that space, and even sometimes the proximity to friends that had been neighbors previously, but now they've moved to a different area of the home. And just wanting to acknowledge that maybe these moves are not always avoidable, but we do have a chance here to notice these losses and have better conversations about supporting people through these transitions. And so, Lisa, I think you will be describing what anticipatory grief looks like
Yeah.
from your experience.
Yeah.
Mhm.
So the emotional suffering and grieving that's felt prior to an upcoming loss is known as anticipatory grief. It's that difficult contradiction of maintaining a strong connection while starting to let go. And it arises the moment we enter long-term care or witness a progressive cognitive decline, for example. For family care partners like me, it's the whole emotional tug of war between wanting to hold on to my dad versus getting ready for the end at the same time. And for staff, anticipatory grief may present when a resident has a medical need, but the care home cannot meet that need in place. So appointments or visits to the ER need to be coordinated, and it's very stressful due to the waits and the unknowns. There are many unknowns in long-term care that cause anticipatory grief. And the next grief
Yeah,
felt is ambiguous grief.
yes.
Ambiguous
So
loss.
I can speak about that. So ambiguous loss is something that's without clear ending or clarity. Example could be you're grieving your loved one with dementia. So the person is still there physically, but they're different from who they were before. Maybe your relationship with the person has changed, the roles, loss of roles, schedule, the routines you had, those have changed. So those are the ambiguous loss. And next is disorientation and disenchantment.
Thank you. Disorientation and disenchantment is similar to expectations versus your reality or experiences. So in long-term care, this can stem from a gap between what we know and what we don't know, which sets up expectations, which can often be misaligned with what actually is. So for example, as families coming into long-term care, residents entering long-term care, they've read on all the government websites that long-term care services provide 24-hour professional supervision and care in a protective, supportive environment for people who have complex needs, et cetera, et cetera. But upon arriving, it's quite evident through no lack of the intent of the care home, but more the model of long-term care that we have in British Columbia, there is often a lack of staffing to provide that constant care and support. And so our expectations may be thinking that there's someone there for you at all times, when in actual fact, that's not entirely possible. Similarly, the resident and family who have experienced, let's say, a fall or a broken hip, believe that they might miraculously recover or even improve by being in long-term care, when the reality is long-term care is really, in many cases, the last stop. And the reality is it's more of a palliative approach to care. So this form of grief can be overwhelming and often felt. Another form of grief is a cumulative grief. Next.
I think that would be me. Thank you.
Yeah.
Yeah, thank you so much. So in long-term care, grief is, as we all know, is a shared experience that influences everyone, including residents, families, and team members. So when we are talking about team members, we are not just focusing on clinical team members. We are meaning, beyond clinical members such as maintenance worker, housekeeping, HR, all team members. It is often cumulative and ongoing as individuals experience multiple loss over the time. The example would be a team member coping with several resident deaths happening within a short period, witnessing residents' ongoing illnesses, functional decline, and suffering over months or years, providing repeated end-of-life care and supporting bereavement families while continuing to care for other residents. Another example is a resident grieving the loss of friends and fellow residents who have died within the care home, and a family member experiencing ongoing grief as they witness the gradual decline of a loved one living with dementia, frailty, or chronic illness. key message is in long-term care, grief is often not a single event, but it's the series of the losses. Resident, family, team members may experience repeated cycle of the loss, change, decline, death, and bereavement. Recognizing and acknowledging these experiences is essential to foster compassionate and trauma-informed best practices in long-term care. The next form of grief would be complicated grief. I can talk about that one too. It is also known as prolonged grief, happens when grief remains intense, persistent, and significantly interferes with the resident's ability to adapt a loss and engage in daily life. While grief is a normal response to loss, individuals experiencing complicated grief may feel stuck in the grieving process with symptoms that continue for months or years. An example would be a resident with advanced dementia dies after living in a long-term care home for a long time. 6 months or a year later, the resident's spouse continues to visit the home frequently and remains unable to accept the death. The spouse may avoid social activities, withdraw from family and friends, remain preoccupied with memories of the deceased, and report that life has lost its meaning. Excuse me. Another example would be a curate developing a close relationship with a resident, which is very common in long-term care. Following the resident's death, a curate experienced persistent sadness, disturbing thought about resident, feeling of guilt that they could have done more, and difficulty concentrating at work. The grief begins to influence their well-being, job satisfaction, and ability to provide care. I guess, Grace, I'm going to pass it on to you now.
Yeah, thanks, Gita. And I think Naoko, were you wanting to speak to the masked grief?
I've just mentioned quickly, so masked grief is just like the word says, covering or suppressing the emotion knowingly or unknowingly. Example could be a staff maybe feeling down and calling in sick, not realizing that he or she is grieving a loss, or residents and families may behave reactively about certain things or come across as being angry, where they may be grieving without noticing it themselves or suppressing the emotions.
Thanks, Naoko. So next slide. So it's clear there's many different types of grief experienced in long-term care. And it's also important to realize that grief rarely exists in isolation. It often interacts with previous life experiences, and that can include trauma. And recognizing that connection helps us better understand why people may respond differently to loss and change. And so Gita will explore the relationship between grief and trauma in long-term care next.
Thank you, Grace. Trauma is very common among the population we care in long-term care, as we all know. Evidence even confirms that older veteran and individuals who have experienced significant or repeated trauma may have even higher rates of trauma exposure. As a result, when providing care in long-term care, it's very important for us to assume that many residents may have a trauma history, even if it's never been formally disclosed. This is going to shift our thinking from what's wrong with the person to what might this person have experienced. Past trauma does not simply disappear with the time. Many different experiences can trigger traumatic memories or worsen previous trauma responses, including illness and functional decline, loss of independence, death of friends and family, and even moving into long-term care home. Many researchers suggest that healthcare setting, medical procedures, and long-term care environment can unintentionally trigger or reawaken trauma responses in some individuals. In residents, trauma may present as refusing care, withdrawal or isolation, agitation, calling out, behavior, distress during personal care or procedures. In families, trauma may present with distrust of the care team, frequent requests for updates, demanding difficulty accepting the changes in condition or prognosis. In staff, trauma may present with burning out, emotional exhaustion, moral distress, reduced empathy. In long-term care, grief and trauma are often interconnected. Repeated losses can activate past trauma, and past trauma can intensify grief responses. By approaching resident families and colleagues with curiosity, compassion, and trauma-informed lens, we can better understand behavior, reduce distress, and create a safer, more supportive care environment for everyone. Later in our presentation, we will focus on what trauma-informed care looks like in practice and how we can apply it in our daily work. Lisa now will walk us through how grief can emerge at different stages of the resident's experience from admission to end of life. Over to you, Lisa.
Thank you, Geeta. So grief occurs across the entire care journey and takes many forms. This slide targets comments from actual residents as to the struggles they experience. Input from them, their families, and care team have informed strategies coming in the next slide to help us combat these struggles. But first, let's define some of the struggles. So during transition into long-term care, loss comes from a sense of fear about the safety and predictability that used to exist at home. Some residents are triggered, especially those with neurocognitive disorders, with a sense of anxiety, panic, and a feeling that this place is unsafe, even though this fear is simply caused by the unknown and change. Loss is experienced because they were used to their home, their schedule, and their agency over their own decisions. So basically, grieving the lifestyle they once had is a struggle. An example of that is at home, drinking a cup of coffee, for example, as the morning routine begins, and maybe reading the newspaper or a favorite book, or watching the news. In the care home, everything is rushed. The one meal, breakfast they liked best is cut short because, of course, there are a couple of seatings. They have to move through the residence to give everybody an opportunity, and it's just not the same. So there is disruption that is a struggle for residents. Some residents mourn the loss also of family and friends who may or may not come to visit any longer. And despite the interaction with staff and residents and other residents, there's a feeling of loneliness in the middle of this crowd. And residents seem to have lost their sense of a comfortable community and can become isolated. Their room becomes their community. It might be filled with the last things that are familiar to them from home and be the only place that they feel comfortable in. On top of that, the food and dining experience, a highlight for most of us in our daily lives, is structured and scheduled. And often residents are seated with strangers who might have odd behaviors or hearing challenges or just not be the kind of person they wish to share a meal with. And residents can become frustrated and upset. And sometimes it results in sort of changing their tables frequently in order to establish a good fit. This example is exacerbated by menu and food quality dissatisfaction, a loss of cultural favorites, personal tastes is now compromised to the lowest denominator of institutionally prepared food. It's not that it's not good, it's just not the same. We mentioned loneliness in the middle of a crowd and the distinct absence of the person who best understood them from their home or hometown. Losing their sense of community and becoming isolated is a top example of a struggle. And the toll of losing a little bit of oneself every day is something they are distinctly aware of. Some residents notice within themselves the loss of self and the roles that they once had, and also the abilities and limitations physically, mentally, and emotionally. This toll also presents challenges for residents and the care team to keep up with this adjusting care plan, and families who are still in disbelief that their loved one isn't getting better. So again, I mentioned the loss of self, not being able to do what they used to safely, which might cause them to try and do things unsafely, resulting in a fall or inability to succeed, which causes further frustration. Residents change over time. Some recognize it and some do not, but they all need help. They all need support to get through these changes mentally, physically, and emotionally. But this support is not textbook and it's not easy. The struggle of support requires time and good listening skills, patience, and providing answers and decisions that are for the resident, not just because it's a rule or must be. So it's difficult. The fear for some residents is that they may die and never be noticed, and there are just too many people passing. Some residents, as I've been told, cannot speak for themselves, so we will never really know what grief and bereavement looks like for them. There is a continuous grief through the loss of resident mind, spirit, and body as they journey from their admitted state to when they take their last breath. Next slide. But fortunately, we have strategies. We have known strategies and strategies yet to come that are all based on first acknowledging that moving into long-term care is a very big and overwhelming transition and that struggles do exist. So during transition into long-term care, what strategies might we use? We might slow down the transition, stage it, or make the transition more easily by downsizing the volume of paperwork that comes on that first day. Maybe it's later in the week for some other forms to be filled out. Similarly, introduction to staff. On the first day, just the staff who need to know. And then throughout the week, introduce other members of the care team who are there to help residents and get to know them. And also information. What's essential on that first day and what's essential in the days and weeks to come. Some residents and families have even found solace in trying out respite stays before entering long-term care in some care homes. And Naoko has examples that further expand on care home strategies. Naoko?
Yes, thank you, Lisa. So I can talk about the practice that we have been doing for the past few years at our care home. So this, it's called Moving Huddle. This was started as a quality improvement project because we saw how difficult the first day was for many new residents and families. So basically, we're front loading a lot of support in the beginning to soften the overwhelmingness of the big transition. Regardless, it is very difficult, but we wanted to ease this transition as much as possible. So what we do is once vacancy is matched to new resident, usually social workers reach out to the family members by phone and ask questions about mainly psychosocial information, because when we receive information about the new person, we already receive medical conditions and care needs information. So we ask family members about the person, what they want to be called. Sometimes the person wants to be called by middle name. How they're feeling about moving into long-term care home. What were their hobbies? What were their life like? And then at the same time, we share information about our care home, which neighborhood they're moving in, what the daily routine is like, and most importantly, we inform them that the first day could be very, very challenging for both resident and family members. And then the day before or the day of the moving, we have moving huddle in the neighborhood where the new person moves in, and we share the information with whole care team, from unit clerk to nursing, allied health, care aides, And it is a good opportunity for staff to be reminded that the person moving in had a whole life before they come to our care home. And if it's possible, we invite family members to this moving huddle so that they can share information about their loved one directly with us. And having communication before the moving helps family members set the expectation. And then after the new person arrives, we write a brief blurb about the person, what they want to be called, approaches, hobbies they enjoy, and so on, and send to all staff at the care home so that everybody in the care home knows that there's new person has moved in. So that's what we have been doing, moving huddle at Minoru.
Such a great strategy. Thanks, Naoko. As Naoko said, fostering relationships and connection and identity of residents during their stay is a strategy that works. To continue to add to this, using supportive care and a relational approach is key. It's not what the care is, but it's how it's provided and delivered, which is so important. And this is across cleaning staff, recreation teams, and even meal servers. For example, staff who opportunistically create time for communication with residents during procedural care will find that their tasks result in better resident outcomes. Physical care could be performed in a way that expresses emotional care and concern. An example of this is to integrate a dignified senior care program that ensures every task that's performed is carried out in a manner that considers the impact of the resident, the person behind the chart, and also considers the staff through self-care so that the outcomes are positive for both. Connecting a resident with resident council also helps provide the resident with this sense of purpose and belonging. Engage resident council or leverage resident council as partners in improving grief-aware practice. Residents can simulate their sense of belonging that they once had in their faith organization, their strata, their professional organization, or even social groups through their council. One resident said, "I live for resident council. It gives me a sense of purpose, well-being, and something to live for." Contributing to something greater than ourselves for residents, the council provides peer-to-peer support. Even a resident who's only been there for 3 months has information that newcomers need and want. And resident councils can elevate the collective concerns and conversations to decision makers for action-focused conversations to improve quality of life. Care homes who engage with councils tend to experience an improved community culture of trust, communication, and collaboration, inviting continuous quality improvement instead of a survey once or twice a year. Geeta mentioned to us about trauma-informed care during a resident stay, which is also a great strategy about asking about more about what happened to you instead of what's wrong with you. It's the approach that makes the resident experience. So recognizing the signs and symptoms and impacts of trauma and responding by implementing education and ways of working and policies that seek to avoid the trauma or re-traumatization is always a key strategy. An example is just understanding that difficult behaviors may be an automatic stress response. Focus on changing the environment or providing flexibility and choice in the resident daily functions and options, and seeking positive strengths-based approach, targeting the ability of a resident versus the disability. Last but not least, a strategy is reminiscent therapy. It's an example of a solution to many struggles. Reflecting and talking about the past achievements and stories with residents helps relate where they were to where they are today. It could be so meaningful. Creating a resident showcase, for example, where the care home showcases the life of a resident can bring joy and meaning to the resident family and the entire village by engaging the resident and asking them questions about their previous life and how they feel they can contribute based on their life to their current community. Then during dying time, it is ideal that residents do not die alone, and that informing families all the way along about what to expect is key. It's very, very helpful. It's a helpful strategy to alleviate misaligned expectations. One way to do this is rituals. They're an extremely effective strategy to help just message the whole village, or at least the wing of the village, that someone is ending their life. Using visual cues of palliation on, for example, a resident door, an image of a sunflower, for example, to indicate that they're receiving palliative care, creates an invitation to slow down and be gentle when visiting or providing care. Likewise, providing something special at the residence table in the communal dining room to let the others in the village know that the person is missing due to a transition is also helpful to give others a chance to say goodbye. And then after death, by sharing and notifying your long-term care village about the death, including the resident council, is important. Just to share the last message of connection. A memorial board has also been chosen as a helpful strategy and an appropriate and respectful place to inform residents and families. And during the entire time, engage residents and their councils as partners as to improve the grief-aware practice. Honoring cultural diversity in grief is also an important strategy, recognizing that grief is shaped by the person's culture, their relationships, their history, and so that their identity and their view on healthy grieving looks different for each person. So practicing guidelines for culturally responsible and responsive end of life for all residents is important. All these pieces of information and resources can be found in the BC Centre for Palliative Care, honoring culture, diversity, and grief as well, just to name a few. So overall, more attention is needed towards a non-death related loss and the cumulative ongoing nature of loss. Not talking about it doesn't work. So communicating about it with those it affects does work as a strategy.
Thanks, Lisa. And so we focused on the resident experience here, but grief also extends far beyond residents to family members as well, who are navigating major transitions, changing roles. And so many of the themes that Lisa's discussed here also appear in the family experience, although maybe sometimes in different ways. So, as a family member herself to someone living in long term care, Lisa will now provide some more information about the family perspective. Next slide.
Thank you. So the next slide. Great. So we'll do the same. Start with the struggles of some of the struggles of families in long-term care. And remember that grief occurs across the entire care journey and takes on many forms. This slide just targets some of the struggles. So during the transition into long-term care, families do struggle with this guilt, this self-blame. Why couldn't I have cared for my loved one at home? This conflicting sense of relief that your loved one's getting care, but the loss of control of that care. Feeling a loss of being the primary caregiver role, reduced to being a visitor on a name tag, can be accompanied by a loss of purpose or sense of failure. Not having a designation such as care partner or designated support person, as some other locations have, is also compounding. The shock at changes after separation, especially since COVID, not seeing your loved one for a while, can also take its toll. Moreover, reeling from uncertainty, just not knowing what you don't know as a family member, is a struggle. So one struggle that we can do something about is feeling unheard or excluded from care conversations or care team decision-making or communication in general. So the struggle it can be misperceived as not knowing that you can speak to the care team, that you can go to nurse's station, and that your care aide can become one of your best friends during your day. There's the toll of losing a little bit of your loved one every day as well. Every day I walk away from my dad, I know walking down the hall that tomorrow may not be the same, and the next day and the next day. So adding on to what you don't know and what's yet to come that you're not sure of is a big struggle, all on top of being in denial for many of our family members. It's no wonder that family members can be emotionally charged and short-fused. Those caring for someone with dementia may experience even higher levels of negative mental health outcomes due to reduced inability to communicate at all with your loved one in your final stages of illness. And this significant and prolonged anticipatory grief goes on due to the loss as dementia worsens. And remember that evidence shows that being emotionally unprepared for death is associated with higher levels of post-death depression and anxiety. So we need to find ways to find solutions to these struggles. Next slide. Right. So there are strategies. So during the transition into long-term care, one can prepare for these, for the expectations. Reflect back to the information Naoko delivered on the move-in huddle. It was described in the resident section and how she said it was very important to involve the family. And that can very swiftly diffuse this emotional buildup and this mistrust, especially at the onset of moving into long-term care. Just the communication alone can provide a sense of relief and calm, and having this bi-directional exchange and opening this welcome direction of exchange questions and information can help prepare and align the expectations. This is key. Knowing your family is important. Are they a difficult family member, or is this a difficult family relationship? There's two different struggles here requiring different strategies. But because you can learn to get to know where the family member is coming from, that can be helpful in how to communicate. How do they perceive themselves generally in dealing with difficult situations? So what do they need? What will help them? How can we help them help provide solutions? Self-care, just knowing that they might benefit from self-care from the outset might be the best offer of support. Supporting the family's well-being. An example is offering support from the Alzheimer's Society. That's something that family councils do very well in inviting them in and finding out what they have to offer. And they have a huge framework of support services. Stress is a really normal reaction in our lives when we feel we're in danger or unable to cope with the situation. And, you know, the first humans needed this innate stress response of flight or flight to stay safe in dangerous worlds. And years later, we still have that same stress reflex, and it can, you know, help us when we're at risk. But it's also very, it's a struggle that we have that needs a strategy. So when we're feeling all of this, a resource from Family Caregivers of BC might be helpful, for example, to provide a wider peer support group, educational webinars, and one-to-one coaching for families. During your time in long-term care for families, the best example I can lend for supporting families in long-term care is family councils. The International Long-Term Care Council's BC website and education portal is designed for families and designed for care home staff to offer many resources. Families often can be overwhelmed with the unanswered questions and concerns about new routines. In this, the family council can support one another. They can be familiar, a community within a community, and they can answer questions. A simple referral to the family council by the care team can be very helpful. From education on where to get your clothing labeled, to where the lost and found is, to how to have a better visit with your loved one with dementia, the family council, like resident council, provides a place for families to go, share, and learn. They can work through their concerns by being empowered to find their own way through their struggles, their own way on their own new caregiver role, and entrusting the care team to do their job and let them deepen their relationships with the care team for a more collaborative and productive conversation. Community support can be found through the Vancouver Coastal Association of Family Councils, for example, the regional association. They can help care homes who don't have a family council, or for care teams who wish to improve or restart their family council. Preparing families for the changes they'll see as they approach the end of life is important. There's so many resources. We just don't know what we don't know. There's As Death Approaches, which is an incredible document that helps. It's an overview of common challenges that connects families with surrounding grief supports, the Canadian Virtual Hospice Grief Resources, so many more. At dying time, ensuring care plans are in order, making sure that families are informed about approaching death. These are strategies to help support their grief and bereavement. And after death, knowing that grief continues, and until the resident has left, dignity walks, memorial boards, a last time room blessing for families who have been unable to get there until the last minute, and for staff to have their last chance to say goodbyes, and offering flexible and accessible locations for families to gather and grieve just one last time in the home that they called home with their loved one is helpful. Helping comfort residents, other residents, and the residents themselves is also a strategy. For residents have said, it's nice to know that you don't just disappear as though you've never been, and that stories have been shared in the room at the last moment, just to have a bit of a blessing. Providing space and time for people to come together as a community is important. This ritual recognizes that the whole village is a team and reminds attendees that others may share their grief. Make sure families do not feel alone. Overall, participation in such experiences help make the death feel real and allow expression of emotions instead of suppression.
Thank you, Lisa. And so that was the focus on the family perspective. And then lastly, we also really wanted to highlight the staff experience. And so Naoko will share from her perspective working in long-term care as a social worker.
Yes. Next slide, please. Oh, yes. So I'm going to talk about first challenges that the staff face with grief on a personal and organizational level. First of all, there's resources don't match role expectations. There's a lack of training or acknowledgement that the long-term care home as a major site of ongoing loss and death. Losses, death, and dying is part of long-term care homes' daily work. However, the emotional part of the work is often not included in the training or in the orientation. It is a systemic issue, but there's so much pressure to admit a new resident soon after another resident's death. And it is traumatizing for families of the deceased and demoralizing for staff. There's a dilemma between demand from the system, but also we want to honor the deceased family's privacy and grief. There's a pressure to suppress grief and move on to the next resident, prioritizing remaining professional, and tension between building close relationships with residents and preserving emotional distance to protect ourselves, and the capacity to deliver care. Staff may feel they must suppress grief to coworkers and managers to look capable and efficient, yet display grief to residents and families to show care and compassion. When staff try to suppress feelings of grief, it can lead to emotional distancing and compassion fatigue, a form of physical, emotional, and spiritual exhaustion that affects their ability to feel and care for others. Also, another challenge could be burnout due to continuous exposure to loss and lack of time, space, and validation or support for grief. Staff may not be always given permission or encouraged to take time to grieve during or after loss and death. Or there's lack of support for grief can exacerbate helplessness, physical and emotional exhaustion, depersonalization towards residents, and sense of diminished personal accomplishment, which affects quality of care provided. There are research implications. Unattended grief is shown to contribute to increased staff turnover and absenteeism, low morale, and poor staff retention, leading to shortages and extra costs of recruiting and orienting new staff. So unattended grief can reduce continuity, consistency, and efficiency of care and service delivered by staff to residents and families, which includes client and family dissatisfaction. And Grace?
Yeah, and so thank you, Naoko. So it's clear that grief is an occupational reality of working in long-term care, and it also insinuates that grief support must also become a part of the organizational practice. And so Naoko will share some of the strategies she's seen that can support staff well-being.
Yes, next slide, please. So I'm going to talk about some strategies, but I'm assuming that some of you who are listening in are working at long-term care home, and maybe you have some practices that you're doing. So maybe you can share in the chat box so that we can all learn from each other. So these strategies are both on personal and organization level. Once again, first of all, it's important to normalize conversation about grief and build confidence in speaking about grief. Naming emotions is a first step to identify our grief. Self-awareness about our own grief helps us to have empathy towards our residents and families. We can cultivate a culture that is open about having these important conversations through education and creating a psychologically safe workplace. The relational care that we're striving for is important for staff as well. So it's not just staff and residents, but among staff. We can work together better when we are caring and supporting each other. And we can raise awareness of importance of grief care by engaging resident and family councils as partners in improving grief care, aware practices. In changing organizational culture, the management or the leadership team can play a big role. Discussions with staff can be held about ideals surrounding distance professionalism versus ideals related to caring relationships, help staff process and develop their professional identity. Organizational culture can include reflective practices that help staff recognize relationship-based whole person care is a key part of being professional. One resource I can mention here is a book called Recipe for Empathy by Deborah Bhakti. I think it can be put in the chat box. I have the book here. So the author worked for many years as an executive in a senior care industry, and also she had her loved ones in long-term care and assisted living. And she writes in this book ways to think, communicate, and connect with residents and their families by design and intention, not by default. She really highlights the importance of transforming our care from transactional or task-focused care to relational care. Another, yes. And then the next thing is make organizational process protocol support for families in nearing and after death open and clear. We can prepare staff how to support families during care journey and after death. For example, we can come up, have a handbook to give, or if staff knows ways to support families who may want to stay overnight for vigil, or staff can share what other families have found helpful, or inquire how the home can best help them. So if we can help staff equipped with knowledge so that they can better support families. Another resource is a Palliative Essentials in Long-Term Care course, which is available on Learning Hub. It's self-paced course. This one particularly is one for nursing and allied health, but there's one in development for healthcare aid. Palliative care, or palliative approach to care, is person-centered and focuses on quality of life, and is more proactive, not reactive, having an anticipatory care planning. So having an education like this early, such as during orientation, is very helpful for staff to work alongside with residents and families, preparing them what to expect in the care journey and end of life. Another resource I can mention is BC Care Providers has a resource called Grief and Loss Resource Sheet. So it compiles resources for staff to support family members through grief and loss. And it does have some information about staff, for staff working in long-term care and assisted living as well. And another strategy is make formal support available for staff. Many other workplaces outside of healthcare do not deal with losses this frequently or continuously. So it is so important to have an opportunity to address grief at work, where we have shared experiences. It could be in a form of debriefing, peer support, direct supervisory support, or EFAP. If there's a spiritual health practitioner person at your work, they can provide support for staff as well, not only for residents and families. And as mentioned earlier, incorporating trauma-informed care in long-term care home is important, and it applies to staff as well. Working in healthcare is prone to trauma. Trauma-informed care recognizes that staff's life and well-being are as essential as their work. It means building resilience and system of support for staff via organizational factors like reasonable care ratio, equitable benefits, peer support, adequate training. So when staff feel safe, heard, and valued, staff can provide even better care and support for residents and families. And rituals are so important. I can't emphasize enough. I think research backs the importance of the rituals in grief care. If the rituals give punctuation after the person's death and helps us to pause and acknowledges their death in our busy work environment. If attending rituals like a memorial service or room blessing is not attainable, staff can spend at least a few minutes during the shift change or report time, acknowledging the deceased resident. It is helpful when management encourages staff to partake in rituals. At our care home, which is a large care home with 250 people, we have about 70 to 80 residents passing away every year. So we have monthly memorial service. And we have also memorial board, as it was mentioned before, and we pass around condolence card. And also we write obituary of the person and send it to all staff by email, just like when we welcome new residents, so that everyone in a care home knows that this person passed away. So lastly but not least, self-care is a very important strategy, because we need to take care of ourselves so that we can be available emotionally and physically for our residents and families.
Yes, thanks, Naoko. And next slide. So, just from understanding the struggles and strategies that have been shared, that all the people making up the long term care village experience, it's clear grief is significant and we can address it in many ways. It's also encouraging that there is some research that's been done to show when we invest the time and resources for grief care, it can be transformational and worthwhile. Since we're a little short on time, I think I might just go through this briefly, but some of the studies around supporting residents with art therapy and supporting staff with different interventions found that for residents, the grief therapy really helped them communicate in another way to find others who have shared experiences and to talk about their grief. With the staff studies, they found when grief support is provided, the positive effect on team bonds was improved. It provided closure after death. And the burnout subscales that they had used to measure these experiences of exhaustion and depersonalization were also decreased. So the research does show some promising findings about the positive outcomes when we do invest time and grief care for the entire long-term care village. Next slide. And so, to bring some of these findings back to lived experience, I'd just like to share one more reflection from a family member who shared what a difference it makes to talk about grief. It helps families grieve along the way, which can help them better navigate and manage the loss. And it can also help them better prepare for decision making because they know their options more. And so, next slide. We did have a few slides just summarizing the resources and the strategies that we talked about today. So the next 4 slides contain those, but we can provide those in the meeting summary. So we can go through the next 4 and just go to slide 28. And Geeta will conclude with a few key messages. One more slide.
Thank you so much, Grace. Can you hear me, Grace, better this time?
Yes, I think so.
Thank you so much. So grief is not a problem to be solved in long-term care. We know that. It's a natural and ongoing reality that should be acknowledged, normalized, and supported. By recognizing grief as part of life in long-term care, we can reduce suffering and honor the experience of resident, family, and staff. This session has aimed to serve as both a practical resource for you and a call for action. Although grief and bereavement are universal experience in long-term care, there is currently no standard approach to support resident families and staff. As we said earlier, today we explored developing practices, shared experience, and reviewed evidence highlighting the importance of making grief visible within long-term care setting. At BC Center for Palliative Care, work is underway to develop educational resources for long-term care professionals as well as quality indicators that support the integration of grief, education, and bereavement. We hope this work will continue to grow and contribute to policies that make grief and bereavement support as a routine, expected, and essential component of quality in long-term care. Final takeaway is grief touches everyone in long-term care. By recognizing, supporting, and responding to grief, we can create more compassionate environment for resident, family, and staff who cared for them. Thank you, Grace. Over to you.
Yes, thank you. Thank you, Geeta, for the closing. And so I think Joshua will be moved just into a very short Q&A. And if there's additional questions we can't answer, I think we can provide responses through the meeting summary document that will be sent later.
Okay, yeah, that's great. And thank you so much, everyone, for presenting and sharing some of your wisdom. I know there's a lot to cover, especially when you're going 3 different types of populations, but I think it's so important. And so I know in the chat we have some questions, so maybe we'll answer some of those. And then, Grace, if you want to put your contact information on the bottom in there, people can maybe send you some questions and the group itself can answer them and we can respond that way. So the first question we have here in the chat is there any issue with privacy or confidentiality when disclosing the decline or the passing of a resident to other residents? . What are your thoughts? Any one of you want to answer?
Uh, my name is Noelle. I'm a social worker at a long-term care home called Little Mountain Place. And kind of to get around that, our team about a year ago started. Uh, we we're able to do this because we have online charting with a different system than the hospital system. But we added in the charting system a special like title called Goals of Care. Um, and basically every single team member, doesn't matter who you are, not just social work, is anyone who has an organic relationship with a resident. Um, Throughout their time, we are to obviously have goal of care conversations kind of within embedded in our conversations and included in that we start kind of asking residents, oh, when it's appropriate, like if you were to get sick, would you want your table mates at dinner time to know? If you were to pass away, would you want, this is our practice, um, family and staff can walk out with someone. Would you want that? And would you want any of your resident friends to attend? That way we can kind of know what they want before, they enter into kind of the end of life stage. And then we document it under that tab so that when they actually get into end of life, we go and we search all the notes under goals of care and we can see if someone's had that conversation and then we are able to tell their table mates and allow their friends to come in and visit them when they're sick or at end of life in palliative care. But yeah, I mean it's not always. I mean, it sounds better than than reality. I think we're doing a much better job in our spiritual. We looped in our spiritual care practitioner so that when the doctor gives end of life kind of orders, if a resident is still aware enough to have a conversation, then I feel like that's kind of when most of our team kind of gets on it with those conversations. Um, or when a friend passes away, we can have those organic conversations with other residents ahead of time. But yeah, after the fact, that's our question too. We just had someone die unexpectedly, and she was totally really at a really great baseline, and it was just unexpected. And she had a lot of friends, and we're also like, so how do we tell? I think what our team has done this time is individually certain team members who have personal relationships with some of her friends have told them one on one, like privately, um, instead of doing like this massive announcement. But yeah, that's a hard question.
Lisa?
I can just reiterate the effectiveness of a memorial board, either recessed into the wall with a light over top, or or maybe even in two places if you've got two floors, or even floor oriented if you've got multiple floors. That way, the people in that vicinity, that community, that wing, can check daily. And it's nothing that has to be verbalized. It's just somebody's picture. And I think it's very helpful to be able to share that. The alternative of not sharing is what I've witnessed, and that's worse to residents and to families. The alternative of not sharing, keeping silent, and having residents wonder where their table mate went, why that person's not at resident council meeting, why they don't show up, and then why they weren't told. I think that the alternative of sharing respectfully is better.
Naoko?
Yes. It depends on the situation too, and so we do have a memorial board, but we asked permission first to the family members because some family members do not want to put their loved one's picture on out there. So we asked permission that when they're declining, majority of our rooms are shared rooms, so we do let the roommate know, not in detail, of course, but you might your roommate is not doing well, and you might start seeing family members more in the room. I think a roommate should know what's happening to some extent. So we do at least that.
That's great. That's a really good question. And we are actually a little bit over time, so we will end it there. And so once again, thank you to all of our presenters for being here today. We really appreciate that. And thank you for all the people who signed up for this. Was our highest registration for any grief and bereavement echo session to date. So it's a very important topic for many people. So we hope everyone enjoyed the session. And when you close this link, you'll get a short survey. We ask that you fill it out if you have time. And registration for the next session titled Understanding and Supporting Complex Grief Among Frontline Workers During the Drug Poisoning Crisis. That is scheduled for September 24th at noon. And then we're going to put a link in the chat. And so to be notified of any other sessions in the series, you can subscribe to our newsletter. And you'll be provided a copy of this recording, any notes from the session, and resources within the next 7 days. So once again, thank you, everyone. And it seems like a lot of people are saying thank you in the chat too. So this was a great presentation, and we hope everyone has a good rest of the day.
Thank you.